Okay, so thank you so much for joining me this afternoon. My name is Rebecca Hubbard. A little bit about me. I have a bachelor's in psychology, a master's in counseling, and a doctorate in human development and family science or human sciences, but that was my focus. I am very passionate about children's mental health and family resilience. And because of that, I have become very passionate about all the systems that engage with families to support children's mental health. And one of those is the primary care setting, which my husband happens to be primary care provider. So I've had a beautiful convergence of my worlds in the program I'm going to share about today. I'm also the mother of 5 amazing daughters who also have their share of struggles with mental health disorders. So my personal and professional lives have been very parallel. I'm going to share today a little bit about integrated care and what that means, and then I'm just going to dive right into the consultative model and what we're building here in Oklahoma. And it's in many other states as well, which is really a beautiful thing because we have big brothers and sisters that can show us the way. But we all know that there's this big need, right, to connect the dots, to connect the systems, to help families get access the care that they need for their child. And part of that is, how do we integrate behavioral health care and general health care? And that's what that's called, integrated behavioral health. And I don't have a lot of slides on this, so I'm going to talk mostly about it, but there are 3 different types of integrated care models primarily. They're a little bit different than the pediatric mental health care model or the, okay, it escaped me, it doesn't matter because it's different. But the 3 are a behavioral health practitioner embedded in the primary care setting, BHC, so that's a co-located. What's the other one? So co-location is when they're there, like we have a behavioral health provider and we have a general physical health provider, right? But we may or may not have a lot of conversation going on. It may just be kind of roll back and forth. BHC is really having that behavioral health provider embedded in the primary care setting in a way that they are communicating a little bit more, maybe collaborating on the care a little bit more, but not anything particularly intentional. The next one, but still effective, still helpful because there is some communication going on. And we're getting better at that model as well, I would add. We're getting better at how to communicate and how to help the behavioral health provider know what the needs are, and then help the general health provider understand what the mental health needs are. The second one, integrated care model, is collaborative care. That is when a psychiatrist is there to provide collaborative care. So they pull the psychiatrist in maybe once a week, and they have maybe 10, 12 cases that they bring in, and they talk to them about these cases, and the psychiatrist provides consultation and tries to increase medication adherence and tries to help with some baseline diagnoses and in-office interventions and those kinds of things, but on a very kind of grouped manner, right? So we bring 10 to 12 cases in and we talk about that. And then we have the consultative model. And the consultative model is really the idea of having access to child and adolescent psychiatrists and licensed mental health professionals to provide consultation, education, and referral assistance to the primary care provider so that the primary care provider can effectively meet the needs of that child with early detection of symptoms, proper diagnosis, assistance with referral, frontline interventions, follow up with referral. Can I get an amen? Because we know that we send them to therapy and they come back and they say, oh, therapy didn't work for me, right? So we're really working to equip these providers also to know how to support family, that they would implement their self-advocacy skills to say, this is what my child needs, and this is what we need to do to get their needs met. So that's a little overview of the integrated behavioral or integrated care. Yeah, thank you for asking a question. So behavioral health embedded in the primary care setting. Yeah, and it's the acronym, of course, because we have a bajillion acronyms, is BHC. And so that's the idea of the the mental health professional is not just co-located with the health professional. They are, they're a little more engaged. They're a little more integrated and engaging in conversation and efforts on certain cases, where the collaborative care is kind of a mass case review, weekly or monthly, even sometimes. The consultative is almost a mentoring, almost I'm coming alongside you. I'm right here, give me a call. We're going to handle this together process. And we're going to talk about that today. So those are called CPAPs. Again, another acronym, Child Psychiatry Access Programs. You'll see they're also called Pediatric Mental Health Care Access Programs, and I'll explain why there's two names here in a second. But these started in 2003 with John, I just forgot John Strauss, Dr. John Strauss, and he said, you know, we really need a way to support primary care providers in assessing and diagnosing and treating mental health disorders when they see them in the clinic. He said, what if we had a line that they could call and child and adolescent psychiatrists could support them? And then they started that, and it went really well. In 2004, Massachusetts Department of Mental Health in Massachusetts said, hey, this is good. Let's make sure this scales up statewide. And they did. And so they went along, and a few other states kind of started trying these a little bit out, not a lot, but a couple tried it. And as these other states started to try to implement these, HRSA took notice, and they said, actually, I'm skipping ahead a little bit. NCPAP was when enough people were doing this program to say, okay, enough of the states are doing this, let's collaborate together and support one another as we continue to grow this. So that was the NCPAP, and I highly recommend checking out their website because you get to see all the different CPAPs that are out there now. And then they incorporated in 2014. This is, well, here, I'm going to skip this a little bit. So, okay, I'm not going to skip it. So PMHCs is Pediatric Mental Health Care Access Program. That's what HRSA called them. So HRSA, Human Resources Services Administration, saw this effort across the United States and said, we really would like to support this. And they received federal funding, which I thought oh, just kidding. What did I do? Okay. All right. Sorry about that. I will not do that again. I lost part of my timeline. So as part of the timeline continues on, HRSA goes to federal funding, and they say, hey, we really go to federal legislation. We really would like appropriations to support seed funding in each state, tribal territory, tribal nations, any kind of American territories, US territories that we can to implement these programs because it's being effective, right? PCPs are reporting more knowledge and confidence in providing mental health care. Children residing within states that will have statewide CPAPs or PMHCAs were more likely to receive mental health services than children in states without one. They saw a decrease in psychotropic use in young Medicaid kids, which is very important. Unfortunately, without this, we often see very young children on psychotropics that they should never be put on just because of the lack of knowledge and trying to make a difference, but making a poor choice because they don't know any better. And a reduction in unnecessary hospitalizations. And if you have not been living under a rock since COVID, you know that hospitalizations and ER visits have been very high and very complex across the nation for children in mental health crisis. So HRSA started funding, I believe it was in 2018, their first cohort. And then they did another one in 2019. So the first one, I believe they had about 14. 2019, they added about 4. So we have about 18 PMHCs at that point, seed funded in their states. In 2019, Virginia started one, and it was so effective. The legislation in Virginia very quickly said, we will give you an appropriations to fully fund this program across the state. So they are kind of our model in a lot of ways, kind of our big sister that is guiding us. They have 5 different teams. They're providing services across the state and seeing a big turn in their access to mental health care for their pediatric population. had a little blip with COVID. And so we didn't have any funding until 2021 go out, and we applied to that, the state of Oklahoma. We had, I'm at Oklahoma State University Center for Health Sciences, and my colleague and I that built this program out for Oklahoma, they came to us and said, hey, would you all be willing to build this out? We'll try to get one of the state agencies to be a supporting agency, because you have to have a state agency to get HRSA funding. And Oklahoma Department of Mental Health was graciously excited about it and said, yes, please, we will absolutely apply in partnership with you and then contract with you to build this out. So in 2021, they received full funding, well, full seed funding, and we started building. And I'm very excited to say that just 1 month ago, yesterday, October 3rd, we launched our program. And I'll share a little bit more about our program, but they now have a little over 40 PMHCA funded CPAPs, right? So they're funded through HRSA. And so we have several US territories. We have most of the states, as you can see, and then we have some tribal nations. So we were fortunate enough that Oklahoma and Chickasaw Nation both received, here in Oklahoma, both received funding. And so we're collaborating with them and very excited to work with them. Their focus is very much on neurodivergence, neurodevelopmental disorders, autism. So they're bringing in many amazing national specialists. And then we are bringing our mental health specialist in together, and we are really co-leading the areas of trying to support these needs across the state of Oklahoma. The other state was Minnesota with the, I believe it was called Red Badge Tribe. Okay, so yeah. Right, so there's just a few that don't have them, as you can see, Utah, South Dakota, and Arizona. And I think our understanding is that they just have not applied, but HRSA is getting ready to release the 2023 funding opportunity, and I believe there's 16 that they can award. So hopefully those states are applying. And if you're from that state, I encourage you to call your local, health department, Department of Mental Health, a university that's very passionate about children's mental health, and advocate for it to be brought to your state. It was actually TriWest, which is a huge national research conglomerate that brought it to us through a partnership they had with a research entity in Oklahoma. Oh, okay. Yes, so we will work. Let's go back to Arizona and find the person to call. Yeah, and I'm happy to connect you with the TriWest people, because maybe they know somebody that's out there working in a different area that would champion it. So yeah, definitely, I'll give you my card and we can connect. I'm a huge collaborator, y'all, so just brace yourself for that. I love collaborating. Yeah. So Oklahoma, if you're not from here, we kind of have some pretty rough numbers. We are ranked 46 for youth with a higher prevalence of mental illness and 33rd for access for care, which is not good numbers. When you add those together, it really means there's many children out there and adolescents that need care and they're not able to access it for a variety of reasons. We also categorize as a severe shortage area for the nation for child and adolescent psychiatrists and behavioral health care in general. Our suicide rate is significantly increased, and we have the second leading cause of death in Oklahoma for 10 to 24-year-olds is suicide, unfortunately. Many factors go into that, and that's another presentation for another day. But suffice it to say, that is exactly why early detection of symptoms in the pediatric primary care setting is vital, because we know that most parents are taking their kids in to see their pediatric practitioner, where they may or may not be taking them to school or to any other gateway point to enter for mental health care. Poverty is known as a social determinant of both physical and mental health. And because of the poverty rate in rural Oklahoma, we particularly have concern. And you'll see a very exciting screen here in a minute. Am I at the end of this one? Yeah. So I had to divide my partner in crime she loves Canva. And so our PowerPoints are massive. And so I had to divide them into 3 to get them here. Yeah. Right. Well, you're definitely asking the right person, because I'm driving everybody bonkers saying we have to make sure that the family is resourced. We have to make sure they have what they need, right? We have to help them know how to navigate the system. So what we did, and I'll take your question in a second, I want to let the people online know that her question is there anything that's being done within the context of this program or elsewhere that is equipping families to know how to navigate the system, to know what to ask for, to know what to expect? So I'd like to pause here for a second and share that we created an advisory board. That was the first thing I did. I said, look, I'm one of those moms, highly resourced. I'm a mental health professional. My husband's a medical professional, highly resourced. And we hit so many brick walls in the system. And thank goodness I knew what I should be getting. I knew what my child should be getting, and I knew how to self-advocate, but even then it was really hard. So that's why I do what I do, literally, because I don't want other family to have to go through that. And if you don't know that, that is an even harder hill to climb. And so I am very, very avid about making sure that family is in there. So we've formed an advisory board that's divided into 5 work groups: provider recruitment, education and training, and sustainability, because we only have seed funding. So we want this to be sustainable. The other 2 are system navigation and mental health referral network. And in the context, if you'd like to be in my systems navigation work group, you're welcome to, because that is what we're doing. We're figuring out what are the tips, what can we impart, impact, and educate in these primary care providers that they pass on to the families so that they have what they need. Because we are under an institutional review board, we're not collecting any PHI or private health information. So we can't connect directly with the families currently, but we can equip the primary care provider with much resources and information. And I'll talk about the mental health referral network too, because that's a big component of that. Actually, let me just go ahead and talk about it, because I love that you guys are being interactive, and then I'll go to the next questions. Absolutely love this. I'd rather do this than give my presentation. I think presentations are blah. So the Systems Nav group is like Joni Bruce with Oklahoma Family Network, which is a sponsor of this, is on that. And Lorna Palmer, who is the executive director of our NAMI, National Alliance on Mental Illness chapter in Oklahoma, is on that. We have some behavioral health practitioners. We have some primary care practitioners. So we want them to help us. How do we best communicate to primary care providers that it in turn is communicated to the family and supports them on how do you navigate, what do you expect on an intake, right? What do you expect in services? What should you see in your child to know whether you're getting the help you need or not, right? How do you navigate and deal with insurance when they deny or you're out of network? Right? So we're creating documentation to support that. The 5th one is the mental health referral network. We have a work group around that is helping us to, we are working on getting a comprehensive mental health network of information across the state of Oklahoma to assist in our referral assistance process. Because I believe unless we put a network of recovery, a mental health network around these families, then we're not sustaining. we are not sustaining mental health. We're putting them right back out in the field after some inpatient, after some outpatient, what have you. And then they're right back in a matter of time because they're overwhelmed. They don't have the tools that they need. They didn't understand what they were even navigating to begin with, all the things, right? So this mental health referral network, we have 8 contact sheets that we're building in what we like to say here in Oklahoma, every nook and cranny. Outpatient services, inpatient services, which is inclusive of intensive outpatient and PCPs, PHPs, partial hospitalization, and crisis response centers. And then also adjunctive situations such as domestic violence and developmental disabilities, and drum roll please, family resources. The family resources is massive, and that's the one we're currently working on. So we will have all this contact information for every area of the state of Oklahoma when our providers call in and they say, we've got a 13-year-old that's struggling with depression with recently divorced parents, mom's having a hard time putting food on the table, rent is past due. Okay, we know the social determinants of health, food, shelter, right? Access to healthcare, access to mental health care. What is available in this area? What can we give them, right? Not only that, on the outpatient behavioral health realm, we are sending out, well, on the outpatient programs, the entities, practices is what we're calling them. And that can be outpatient, developmental disability, can be anything. We're also asking questions like age ranges served, special populations served, insurances, et cetera, right? At the provider level, we're sending out surveys to get that kind of granular data, right? So what do you have the most expertise in? Top 3 age ranges. And I give them like 8 choices. Top 3 special populations. So we have LGBTQ, we have African American, Native American, First people, and also like hearing impaired, sight impaired, right? And then more than that, but all of that. And then top 7 diagnoses you have the most expertise with. And we give them a list of modalities that they're certified in, modalities they're trained but not certified in, modalities they're trained and supervised in but not certified, right? So certified, supervised, trained, so that we can really look and see, okay, we have a 18-year-old Asian American young woman who identifies as LGBTQAI, and she is struggling with substance use disorder and maybe some domestic violence in a recent relationship. Okay, we can find those providers that would best meet her needs and try to give the family a good options of fit, but not only just good options of fit for therapy, and then equip them, right, with self-advocacy skills, follow up, continuity of care, but then also, what are the other resources? Oh, there's an LGBTQ support group down the road, right? Oh, there's this for, you know, whatever it is. So we really want to help create that network around the family so that their recovery is sustained. And I know that's beyond what you asked me. Okay, thank you. There was a question in the back. Let me see if I've answered it yet. Did you still have your question? Okay, great, thanks. Yeah. Mm-hmm. Right. It's just a referral network. So the question is, how are we just referring to these different entities, or are we incorporating them in the net as part of what we're doing, right? And so on this part, we are referring, but not just a referral like, hey, I'm referring this person to you, right? It's a, hey, mom and dad, or mom or dad, whoever, grandma, here's what is available in your resources. And then we work alongside, just like we would with, okay, we think this looks like ADHD, but let's do the Vanderbilt, and then let's assess again at the next meeting, and let's talk about some, let's see what this teacher has to say. Let's get a Vanderbilt from the teacher as well, right? So just like we would go alongside the primary care provider with diagnostics or medication management or in-office intervention, we're going to do that on the referral process as well. So we're going to be giving this information and then saying, hey, did you reach out to that resource? How did that go? Has it been helpful? Do you feel like something like that, but different, if that wasn't helpful, would be helpful? We can try to find it for you, right? So it's really about equipping the family with what they have resourced. A lot of people don't know what they have available to them. We often have these amazing services and all these resources. We have all these people who need them, but they don't know that they're out there. And so it's really about creating that network. It will cost $2.2 million a year to run our statewide program just with our child and adolescent psychiatrists, licensed mental health professionals, and care coordinators, and keeping that referral network up to date. Right. So what we have had conversations. So I'm very close with Jenny Bruce, who is our Oklahoma Family Network. She is our NFFCMH chapter, and she serves on our advisory board, as well as NAMI. I serve on the Tulsa board, and Lorna comes here, or is a part of our work group. And so Ann Leandra Moore, who works, she does care coordination all across the state of Oklahoma through community medical health systems. So we're talking to a lot of them. We also have Sooner Care, which is another care coordinator. So we're talking about how do we have our care coordinator work with other care coordinators across the state? Because again, we don't have private information. The best we're going to know is a race and ethnicity, an age range, and a general location for a child. We're never going to know the family, have names or anything like that. And this also strategic because our pediatric providers, we don't want them to feel like we're going to take their patients or anything like that. We want them to know we're supporting them in their care. Yeah. So yeah. Yeah. So the question is there any way to directly engage with families? So not through this program because of the institutional review board. If we collect PHI, it totally changes the game for us. However, there is the possibility under my title that I have at OSU CHS that I would eventually create an arm that would be able to engage with family. But we're not there yet. And so right now it's very strictly primary care interaction to support the family and the child. Additionally, the secret is on this mental health referral network, the secret is that I want it outward facing. And our grantor is very excited about that as well. So we're hoping that in 2 to 3 years, when it's all built and we've piloted it in the program, we can create a outward facing web-based access information tool for that mom in Durant, Oklahoma at 10 o'clock at night, right? For that dad or brother in Shakota, Oklahoma, to get on there and say, okay, this is what's going on. What do we have here that can help us? So I'm definitely right there on the same like wavelength. I want that so bad. And so that's phase 2. Yeah. So as mentioned, this is a primary care provider support to really help address the needs, early detection of symptoms. So we did a PNA, provider needs assessment. Man, we have so many acronyms. So this was the breakdown. Allopathic is MD, osteopathic DO, which is about comparable to what we have in our state. And we have a couple of registered nurses and a couple of physician assistants, which is really exciting because we didn't even target them. Our allopathic and osteopathic boards serve on our provider recruitment work group, and they are huge champions. They are so great. They just sent out our program to over 7,000 providers, and that's what they did with this. Oh my gosh. Okay. 50% pediatricians, 31% family medicine, a couple of internal medicines, and we had some other. And believe it or not, we had plastic surgeon that responded. We had some, let's see, what else did we have? Again, endocrinologist, you know, just some specialists that had some interest. So this is the rule thing that I alluded to earlier. This is a picture that our data manager made. And this is so super exciting for us because we were, and it was very key for us because we were going to do our first year in Tulsa only, and then go to the eastern side rural of the state the second year. And then the third year, which was really the second and third years, because the first year we were building the foundation. Then we were going to come to Oklahoma City and then to the western rural. But when we got our results back and we said, wow, there's a lot of rural physicians, because even those ones that are close to the big bubbles that are Tulsa and Oklahoma City, those are kind of near rural communities. I don't know how many of you are from Claremore and familiar with Claremore, Oklahoma, but like Claremore is 30 minutes outside of Tulsa, but it's considered rural. So those are going to be the areas. Same here, like in Oklahoma City, you've got Norman, Moore, Edmond, you've got Purcell is actually quite near, but very rural. So what we saw was this kind of broad sweeping pattern of our rural providers saying, yes, please. We need help, right? Almost 50% of our responses were strictly rural providers. So we decided that when we launched, we would launch to the entire state. And then we held our breath. It worked out. That's the good news. We asked a few questions. Do you need psychiatric consultation? You know, do you want to pick up the phone and talk to a psychiatrist? Do you want referral assistance? Do you want to help getting therapeutic services and additional services for your kiddos? Does your provider need education? Does your staff need education? And so what we found was 89% said, yes, please help us with referral assistance, 80% on psychiatry consultation. Then we did qualitative interviews. So we said, hey, would you all like to talk to us? And the surprising thing was that we had 210 very busy primary care providers respond, and then we had 130 say, yeah, let me talk to you, which really shows commitment. So we were limited on time, so we set some times, and the providers that could make it, we did 20 primary care, well, I did 20 primary care provider interviews. And we learned, especially if you're a rural state, this is something, you know, from a rural state, this is probably pretty parallel to your experiences there. The primary care providers were saying, and this is why I say rural, is most of these providers I interviewed were rural providers. We need medication management, both beyond the initial evaluation and post-discharge. Well, I've been listening to my husband, and I've been sitting in offices with kiddos that come out of inpatient and they're on multiple medications, and yes, they're calm, but they're not very functional. If you want them to go to school, you want them to engage with family, etc. And if you went into primary care, you had very little training on psychotropic medications. So luckily, my partner in this and her other partner, she's also in the department with us at Psychiatry and Behavioral Sciences. They created a psychotropic, pediatric psychotropic guide for the state of Oklahoma. And that has been a really beautiful resource for us in the context of this as well. So that really, we're able to come alongside providers and say, okay, you can take this medication down to this and this one down to this, and then let's evaluate where they're at. And then we can move into this next phase, right? And really not pull everything away and send them right back into crisis, right? But really helping them to stabilize. There should be a follow-up, but unfortunately there's often a wait, and it just, people fall through the cracks because there's not enough continuity of care, and not enough provision of child and adolescent psychiatrists. They say they're like unicorns, and I'd have to agree. Just few and far between. The grass is always greener. There's a lot of challenge in Oklahoma. So she was saying that Oklahoma has such great family support partners and that kind of thing. And you're right. And we have really tried to implement that. But then I look at Massachusetts or Maryland, and I go, oh my gosh, I want family support workers in all my schools. Right? Right? Yes. Okay. Yeah. Yeah. Yes. Maryland University implemented a family navigator. So through the NIMH, there's the family navigator model, and Maryland took it into the schools just a few years ago. And I think family navigators should be everywhere. I think they should be in primary care settings. I think they should be in schools. I think they should be in the juvenile justice system. I think they should be in every system that engages with, they should be at the colleges. I know that's tricky because of FERPA and all of that, federal education, blah, 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 law. So yeah. So help with developmental and complex diagnoses, and obviously referral assistance, but also being the good therapist that I am, if you had a magic wand, what would you put in your office today? And they said an in-house psychiatrist, counselor, or case manager generally is what they said, which again, we don't have enough of them. She just said, 6-month wait. I'm telling you, child and adolescent psychiatrists, very, very short on that. Case manager's a little bit better, but that's difficult. Here are a couple of interesting news. Speaking of challenges in different states, here are a couple of things that we found, and we kind of knew a couple of these. One, parents don't really understand mental health in a lot of ways generally. We have some understanding, and it's getting better, but really working to lower that stigma and raise that knowledge base, right? It's something that the primary care providers indicated as a need. Also, the complex cases, when you do have a need for a higher level of care, we are struggling. We send a lot of them to Texas, and then they're far away from their family. So what good, Yeah, and so there's so much. Yeah. Rural services are very limited. When you see those shortages for behavioral health providers, they're very poignant in the rural areas. And then we have limited access for telehealth and teletherapy. I was meeting with somebody down in the Idabel area, which is the southeast corner. She said a lot of primary care providers don't even carry a cell phone because once they go around that mountain, it won't ring. Not to mention being able to have telehealth or teletherapy, right? Because if you don't have services, okay, well, let's get you into teletherapy. Oh, you don't have access to internet and you don't have a laptop, okay, or a computer. Okay, now what, right? So we started, this is me. If there's a barrier in the way, especially for children's mental health and their family, I want to remove it, figure out a way over it, or figure out a way around it. And so we already are brainstorming with, okay, can we work with schools? Can we work with libraries for confidential, placements of time and place for them to receive therapeutic services? Right. Yeah. Right. So one of the things that the state of Oklahoma is trying to do, we have like over 400 school districts, which is really interesting. One of the State Department of Education efforts is to try to get a multi-tiered systems of support in all of the schools. So that means they can have that kind of triage process into behavioral health services. So if they're just struggling a little bit we can pop them into a little group, try to give them some skills, some tools to stay in class and kind of adjust, right? But if they're struggling a little bit and they can't get it there, or it needs a higher level of care, then we can go into embedded services or et cetera, right? So there's 3 different levels, and that again is another presentation. But our hope, or my hope anyways, is that the MTSS will all be built within their systems when we get finished here, and then we can support at that higher level across. Many of the PMHCs are currently expanding into schools in other states. So talk about grass is greener on the other side. There are other states, Massachusetts, obviously. There were so many. There was one that presented yesterday and I can't remember their name, but it's irrelevant. You won't remember either when you leave. But they are, so HRSA said, hey, we want to give you more money. Can you expand? And we were just launching too. So we're like, oh, okay. So we're doing some expansion, but not into the schools yet. We're expanding more into the ED and supporting emergency room docs. So I think when the MTSS is built in Oklahoma in the systems, then we'll be able to bridge across and support their care that way. Yeah. Yeah. Wow. Okay. So she was sharing for anybody that might be online. She was sharing that it's interesting that we refer people down to Texas because she's in Arizona and she has several clients that are referred in Ada, Oklahoma right now for residential care. So yeah, that's kind of interesting. It's like we're all shuffling them around and pulling them away from their families, right? Huh. Yeah. Right. Right. Yes. Right. Right. And a lot of times, I mean, family, they don't know what is helpful and what's not. And I will tell you, so I have a child. One of my children has severe OCD, and she's also brilliant. And she has taught me more about mental health than all of my degrees combined. And things that I thought, I'm like, I don't stigmatize. I don't do this. I don't do, and she said, there were little things like, Mom, when you say, I love you no matter what, I was like, oh, wow. Okay. I don't mean it that way. She's like, I know. But when you say, I love you no matter what, it feels like there's a part of me that maybe you don't like or you don't love. And that's the other thing is we have to listen. We have to hear kids and we have to hear families and we have to adjust like you just did there, like fix, oh, that's the wrong word. Like we need to do that. And it's okay to take that humble stance and say, okay, no, that's not what I mean, and thank you for sharing that with me so that I can grow and do better. Right. Okay. So you guys are so much fun. You are my favorite audience so far ever. That's awesome. And you're in Tulsa. So yeah, you are so coming to my advisory board. I'm like, yeah. That's okay. I will take it. I'm good with that. Okay, so we have 3 arms of what we offer: child and adolescent, psychiatry, mental health consultation. So when you call our line, you're going to talk to our licensed mental health professional consultant who's going to kind of get what's going on, how can I help you, what are the needs. Now you may call as a primary care provider and say, I don't need your help, I need medication. for this kid. I need to talk to the child and adolescent psychiatrist. That's okay. We'll move you on. We'll get what we need. We'll move you on to them. But if not, if we can help with diagnosis or frontline intervention or that family support and patient advocacy arm, right, we're going to do that there. And then our specialty consultation, we're adding substance use and suicide prevention to our education. So the suicide prevention will be part of our education and our resources. We can't really consult, obviously, on suicide prevention because that's a crisis, but we're going to warm hand off to 988 here in Oklahoma, and or a local crisis resource center for that family or the youth. Actually, what I found out the other day is 988 is actually really just sending it to the youth mobile crisis line. So I need to talk to the powers that be and figure out the most direct route to do that. But we're also providing specific education around suicide prevention and substance use disorder. And we're going to be really intentional about recruiting ED docs through that process and really trying to help them see the value of this. We can't do 24/7. And actually one of those other providers was an ED doc that filled it out and emailed me ecstatic, so excited about this program. And so we explained we can still do it, but we are only open 9 a.m. to 5 p.m. because, you know, I have 3 child and adolescent psychiatrists that have to split the time to cover that because they have their own patients, they have other things that they have to do. The education is uber cool. And I pulled out a bunch of the slides, but I think that worked out great because we've been chatting. But my partner, Dr. Cheshire, has built out a beautiful process of education for primary care providers, including asynchronous online modules, lunch and learns with case dissections. We do a newsletter. Each of those goes out monthly. We have a theme. So like October was anxiety. So we went with the Chickasaw Nation down in Ada and we presented on a case on anxiety, and we sent out a newsletter. And in the newsletter, not only do we have medical pearls and mental health pearls related to anxiety, but we also have resources that are there for the provider and the families. And we have caring for yourself for the provider. So that's another component that we're really hopeful to kind of wrap in there to really support providers. The asynchronous online modules, the specialty training, we have one coming up in April, and those are a one-day in-person training. And the lunch and learns, they can all get free CME. So that's pretty cool because normally, you know, if you do all of those and you get free CME for the year, you don't have to go to a conference and pay $500 to $1,000 to get your CME, right? And then we'll have our online learning library, which will link to our ECHOs, which are these kind of online learning platforms that we utilize to equip particularly rural providers, but also all of this other information and additional resources that we build. And these asynchronous modules are so cool. She used something called Articulate 360. So it literally walks the pediatric provider through the office visit. It says, you know, you ask this, they say this, then what? And you have your options. And if you choose the wrong one, it says, well, that's not the best option because, you know, they might feel overwhelmed with all that or, you know, what have you. And then if you choose the correct one, it says, yes, that's correct because it affirms mom's concerns, but doesn't overwhelm her, blah, 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 right? So it really does a lot of that. It has the psychotropic medication guides for those, that diagnosis. It has family resources built into it that they can print off right there from the online module or link to and share. So it really walks through the whole kind of like motivational interviewing, empathy, resourcing process to really try to make a very beneficial, effective meeting between the primary care provider and their patient and family. I feel like I was going to say something else about these, but I don't. Oh, the anxiety module. Anxiety was October. We did depression for November. No, ADHD. I apologize. ADHD for November. So that's up and running. And we do She Speaks in Tahlequah. So the rural thing. So we decided to go out across the state for all of our lunch and learns and go into rural areas. I've also lived in 2 rural areas of Oklahoma, so they're near and dear to my heart. But when we go out rurally, they can also Zoom in and the providers can zoom in. So even if we're in Lawton and they're in Tahlequah, they can zoom. So she's going to go speak on ADHD. I'll speak on suicide prevention and substance use disorder later in the year. She speaks on trauma, I think, in January. Okay, and this is mental health referral sources and services that I was mentioning before. Our whole goal is to get that best fit for referral assistance, right? We want to make sure we provide local and statewide resources and services, and to provide follow-up and continuity of care with the provider, as in, kind of scaffolding the provider with the family, and teaching family and patient advocacy and empowerment. We also have, we have a website. It's www.okcapmap.org. And we have on there, we have the consultation page, the education page, and then we have provider resources and family resources. We were very busy on getting ready to launch, post-website launch. So there's, I don't know, like maybe 20 patient information or family information on the resources. I'm wanting to build it out even more. So if anybody, if anybody's from Oklahoma and they're like, oh, this resource would be great, let me know. I'm going to put it in. I used to work at Mental Health Association. One of my colleagues that I worked with there started a little pamphlet about what parents can expect when their child has to leave school to get care and then come back to school. And they finished it this year. So they provided me that warm link, and I can warm link to that so that parents can have that, providers can provide it, providers can send them to the family resource page on our page to peruse the local, state, and national resources. It's live. Yeah, everything's live. If you call 918-710-3600 right now, you're going to talk to Christina. And the website, if you look up www.okcapmap.org, you're going to come to our page and be able to peruse around that. You have to be a registered provider to go into the learning library. You can, as a behavioral health practitioner, you can, as long as you have an MPI number, you can register, like I'm registered. So you can go and register, and you can go in and watch the modules. You won't get any continuing education, but you can watch them. It's a little wonky because we had to make it go through our CME department so that they could, but it's not terrible. It's just not pretty. We like things pretty. So we're like, oh, this is wonky. So it is free. It is seed funding right now. We have been having massive conversations with third-party payers. We've met with Humana, Blue Cross Blue Shield, Oklahoma Complete Health, community care. United gave us a lovely grant, small grant, to help with some of this. So like, they have been incredibly supportive. We've been meeting with some legislators as well. I do a lot of policy work above and beyond this. The student mental health education bill that passed last year was my brain baby. That and the 1868 that got kicked out, the school staff training, but I think he wants to try that again. So we'll see. But, the state of Virginia fully funded this. Where are you all from? I'm curious. Arizona. So Solari is our answering service out of Arizona for Oklahoma for the 988 system. Okay. Yeah. Okay. Yeah. Okay. Yeah, no, tell them to tell their primary care provider to sign up for this, and we will help them through this program. I wish it was direct care because I do prefer that, but I am excited that we're able to support primary care too. But I get it. It is, people are afraid. And so, yeah, tell them to have their, so Arizona, Texas. See, in Texas is program is a part of multiple programs. So there's this called, I want to say CP. Yeah. Oh, okay. Uh-huh. So, yes. So because we don't, yeah, yours is a little more integrated with these other systems. So it's the way I see it is it's kind of like the MTSS, Oklahoma City Public Schools with their MTSS. They made this beautiful multiple page plan, and then they tried to implement it. It was kind of this big bureaucratic, like, okay, how do we make this work now? Where Tulsa Public Schools said, okay, we're not going to plan, we're just going to start building, you know? And so they kind of do this whole like, oh, here's a piece, here's a piece. We don't know what's happening, but we're building a piece. Which I work with both of these schools and I adore their mental health people. So I'm definitely not speaking ill of either one of them. But they took two different approaches. That's okay. That's okay. And so for us, we're kind of here's a piece, and then maybe we can have that piece, and then we can add this piece, right? We all are more we have this big thing now, and yeah. Mm-hmm. Mm-hmm. Okay. He's where? Oh, yeah. Oh, oh, okay. Where does he live? Ah, aw. Well, I had to drive through Utah in a massive snowstorm. So Utah and Washington and Nevada, they don't exist to me anymore because that was very stressful. Where are you from? Connecticut. So she was talking about, for those that might be online, the positive peer pressure from state to state to say, hey, get on board and let's have in Connecticut what you have in Massachusetts, or let's have in Texas what you have in Oklahoma, or vice versa, all those kinds of things. So yeah, right. Mm-hmm. Rhode Island was one of them that presented yesterday or Wednesday, whenever that webinar was. And they presented on a psychiatry, I think it was PRN, psychiatry referral network. Like it was basically kind of these learning cohorts for psychiatry, but also for children, but also for maternal, like pregnancy, OB, like, I don't know. I don't remember. I was not feeling well that day, so I didn't absorb very much. But they were presenting, and there are some areas that some states are saying, okay, we'll allow these 3 states that border us to have licensure in our state, like behavioral health licensure, reciprocity, which don't even get me started on that. There's a whole thing there. Okay. Guam, awesome. There is a CPAP and PMHCA in Guam. I believe it was in the 2021 cohort with us. Yeah. Mm. Right. Yes, I hear you. So for those online, he was sharing that he's from Guam and they only have one psychiatrist and two psychologists and they're aging out. They're ready to retire. So there's this whole system that is, as well with behavioral health practitioners, there's a lot, it's a very close-knit group. They all know each other. And so there's a lot of need to shift and grow and limits with where they're at. And, you know, it was mentioned earlier about like, covering it with fees or forget the word, capitated, blah, blah, blah. So I'm not very good with finances, but yeah. Yeah, capitated. Okay, so we cannot do fee for service because we have no PHI. So what Dr. Strauss said, the best that they've found is doing a flat fee. So with the third party payer, okay, Blue Cross Blue Shield, you have X percentage of kids in the state of Oklahoma. Will you cover that percentage of our fee, our expenses for the year? And, you know, Medicaid, same with you, which we're feeling pretty positive about Medicaid. We do have an RFP that's gone out, that's people are applying for a private contract for Medicaid. So if all of that goes through and processes, our understanding is that Medicaid, our Medicaid entity, Oklahoma Healthcare Authority, does want this to be a part of services, and the providers that are applying for that are very on board with that as well. So we're feeling some really, I think that's the key, is to really get to those third-party payers and to get to those legislators and those high-up university professionals and get them all together and say, how do we support the network that's collapsing in so many, or non-existent, or siloed in almost every state? So how do we pull it together, right? And create the connection and the continuity from system to system. Okay. I can't, no, in front of you. I'm trying to think of colors. Burgundy. Where are you from? Your burgundy sweater. You're from Oklahoma City. Awesome. Awesome. Thank you for being here. She's like, I know all about Oklahoma. All right. Well, make sure you share our stuff. This is how it works when they call, which we've talked a lot about that. And then there's my information and Dr. Chester's information. Where are you from? Georgia. I love Georgia. Right. Yeah. Or you're implementing it, but nobody knows it's there. Right. 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 And that's one of the things that's a struggle for me, because primary care providers in the state of Oklahoma typically don't get, because really for us, it's like we can either confirm nor deny that we are providing treatment for that child. Like that's what we say. And so being able to communicate, you've got to have ROIs, a release of information on both sides, and you really have to have all your T's crossed and your I's dotted, and then you can. But it gets complicated, and we're hoping that we can really work with both sides to break that barrier down for them, and that they'll start to do that. True. True. Yeah. Yeah. So there are three. You're right. It's the behavioral health, the general health, and the parent. And I have parents that come in, they won't even let me file insurance. They don't want anybody to know their kid is in therapy. And others are like, they're signing ROIs left and right. Please talk to this person. Please talk to that person. Right. Because they're desperate. And I understand that. And I understand the other side too. They're afraid of the stigma. They're afraid that a label will hinder their child's capacity and abilities because of the way the systems work, which is why I love doing systems work, because I'm all about changing those barriers, right? And you are from, drum roll, please. Wow. Yes. I know. That's wow. So she's from Tulsa, Oklahoma, and she's having someone ask her to notarize the release of information. To notarize the Vanderbilt? What? Yes. Yeah. Pieces. Mm-hmm. There are a lot of moving pieces, and there's really a need for all of the systems, and there's another thing I run that's actually going right now, but my buddy is heading it up, is the Children's Mental Health Resilience Coalition. So Tulsa was selected as one of the top 100 resilient cities by this global entity a number of years ago. And so they make a plan to become more resilient. So the idea is that each city that they select has enough infrastructure to become resilient, but they're not already, a resilient community fully. And so as part of that plan, they did the 10-year mental health plan, but they also, in the second quarter of 20, how would that be the second quarter? Because it was February, but anyways, February of 2020, right before COVID happened, another psychiatrist from our competing school, OU, and I went and met with our chief resilience officer and said, hey, children's mental health is really struggling in our city and our state. What can we do to make a difference? She lived in Utah, saw some wonderful things there. And luckily, our chief resilience officer is also very focused on children and families. In fact, she was very shocked. She's from New York. She's very shocked to find that Tulsa has no budget line for families and children at all in our city budget. So she's been working on that, but we formed the Children's Mental Health. She said, what do we need to do? And I said, well, we've got these behavioral health coalitions that are going, right? And that was when I was at MHA, and that was my person that was working that. And I said, but each county has one. I said, but we don't really connect the other systems very well. We have all these other systems that are engaging with families and their children, like juvenile justice, higher ed and research, medicine, faith-based communities, community-based entities. I feel like I'm forgetting education, K through 12 education. I said, I'd really like to convene representatives from each of those systems in the city of Oklahoma, or in the city of Tulsa, and just brainstorm together on how we can support the behavioral health system in Tulsa, and how can we just come alongside them, right? And so we did. We pulled them together, and we ended up forming a commission, and we did an inventory of services in Oklahoma and, Tulsa, sorry, in Tulsa, and recommendations that should be released very soon. So be on the lookout for that if you're from Oklahoma or in Tulsa for sure. But we also moved it statewide. And so we meet once a month online, and it's all kinds of representatives from those different systems that engage around children's health, children's mental health, and family resilience. And we collaborate, we validate each other and the work we're doing. We look for places to collaborate. We bring up problems and try to innovate solutions. You know, maybe in Enid, they say, oh, we have this thing going on. And then somebody hears that and says, oh, well, you know, over here in Idabel, we had that a couple of years ago and we did this, maybe it'll work for you, right? So it's that kind of thing that we had going on system to system within Tulsa, that we're trying to do system and community to system and community across the state. And so we meet once a month on Fridays online to do that, to validate, collaborate, innovate, and facilitate the work that's already being done, right? Because they are trying. The behavioral health systems, they're trying, but it's a heavy lift, and we need all of our systems to come alongside and link. So that's another thing that I do. I don't know why that has US, it should have a C on it, but anyways, because I'm finally finishing my LPC. I was almost done, well, not almost done, I was in it, and then I got accepted to my doctoral program, and you can't really do two of those at once with kids. So any other questions, thoughts, anybody wants to share? There is one in Connecticut. Yeah, yes, find them. And if you can't find them, you can come get my card, message me, I'll get you to them. So thank you all so much. It was very fun spending this time with you.